yeah. What's up, everybody? Good morning from cold Iowa. I'm Dr. Nate Noble. Welcome to Developmental-Behavioral Pediatrics Live. Today's topics include the following: the 4 reasons why kids don't talk. Listen, if I had to summarize the number one reason for a referral to the Developmental Behavioral Clinic, probably across the country, it's the child who doesn't talk or doesn't talk well. Okay. And there's a lot of things to think about. There's a lot of different ways to evaluate that question. We're going to talk about it today. And then the second thing we're going to talk about, as you see on the bottom here, we're going to talk about pharmacologic forecasting. Okay. Now that's a separate topic. And essentially what it is, it's me telling you how you need to think, or how your provider needs to think about medications in general. And as I've said in other live streams, do we want medications for kids? Nope. No, we don't. But if we're going to use them, let's use them correctly. All right. For those of you who I'm just meeting, I'm Dr. Nate Noble, Developmental Behavioral Pediatrician, Clinical Geneticist, and host of the Developmental Pediatrics Live internet show. The only Developmental Peds Live internet show on the internet, probably. All right. This is live for a reason. Okay. Not only because I want to get information to you quickly, but because I want to give the opportunity to ask your questions. So if you have questions, you just got to put them in the chat or in the comments on the upload, and I'll see it, and we'll do the best we can to get back to you with either a direct answer or a future live stream topic. And of course, it's not the internet and it's not YouTube if I don't say, look, if you don't like and subscribe, people who really need this information are never going to get it. Okay. I promise you they won't. So if you see any redeeming value, like and subscribe, and let's get started. Okay. So again, ground rules. Remember, if you put a question up, I'm going to put it on the screen. So don't put a question up unless you really want me to show it. If you don't, just put in capital letters like "Don't show this, Noble," and just read it and talk about it. I'll say, okay. So let's get started. I want to talk to you first about the 4 reasons why children don't talk. Okay. Now that's a bit of a misnomer, because there's a lot of things you need to define. Like, well, what do you mean by talk? And what do you mean by, what's a late talker? And what, maybe it's just, there's a lot of questions. Okay. And I don't mean to dive into the weeds on all of those topics. I want to start with giving you a broad construct on how I think about this problem as a developmental behavioral pediatrician, and how I want you to consider thinking about this problem. And I would submit to you that in general, there are 4 reasons why children don't talk that I want to discuss with you today. The first of which is hearing. Okay. Now that's an obvious one. You're like, Noble, of course. Like, if a child is unable to hear, they're not able to, in a timely or neurodevelopmentally appropriate time to access language or to begin to use language in an appropriate manner. Yes, you are correct. But I share this as we start, because every story, when you're evaluating a child with a speech delay, every story should start here. Okay. And again, people have different perspectives. This is my perspective. Okay. And I'll tell you a story. I'm at the University of Iowa. Okay. Go Hawks. I'm there and doing my fellowship training, and I see a kid, and he's fantastic. He's referred for speech delay, and we're talking, and he's looking at me, and I'm telling him to write stuff down, and he's writing stuff down. I'm thinking, okay, well, maybe this guy's got a, speech related issue that's, which we'll talk about next. But then I noticed that whenever he looked away from me, and he would write stuff down, I would talk to his family, and I would say something to him, over the shoulder, like, hey, now draw this or draw that. And whenever I would say the thing without him looking at me, he would not do the thing. You know what I mean? He would do the thing. And because he couldn't hear me very well, he got really, really good at reading my facial expressions, reading my lips, or, all these amazing compensatory strategies that these children can employ. And I realized that we need to put audiology on the schedule that day. This audiology was not on the schedule for that kid. We put audiology on the schedule. Yep. That kid needed, some augmentation, some hearing evaluations. And that opens up another set of doors for another time. But the story starts with a hearing evaluation. Now you might be saying, well, wait a second. My child had a hearing evaluation when they were an infant. I said, okay, yep. That's good. I'm glad that they did. But a lot can change. Okay. Some hearing difficulties, some hearing loss can present not necessarily at birth, but over, a period of time. And so you have to assess and reassess when you're dealing with a language delay. Who does that? Audiology does that, an audiologist. Now, there's audiologists in your schools. So if your child's enrolled in early childhood special education or has an IEP, there is an audiologist likely on that team, maybe on the periphery, that could assess that child's hearing. There's also audiologists in many ear, nose, and throat clinics or in clinics all on their own. And that often requires referral from your primary care provider. So please think about that if you're concerned about hearing loss. Okay. So that's the first of the four. Okay. And again, this is how I think about it. And this is what I talk to families about when a child's been referred to me. Is it a hearing evaluation? Is it a hearing issue? Usually it's not, but it can be. Number two, let's talk about the second reason kids don't talk well. The second reason kids don't talk well is because they have a speech language disorder. And I know what you're thinking. You're thinking, well, yes, isn't that the whole point of this? Yes. But again, when we're doing these evaluations, we have to figure out okay, but is it speech language period, or is it speech language ... And if it's speech language period, there's maybe nothing else I'm concerned about of the four things we're going to discuss. Well, now we need to get a little deeper and figure out, well, what kind of speech language problem? And again, speech language pathologists are amazing people. They can dice out the nuances of this much better than I can. But here's a 30,000-foot view. When I come in, I'm concerned, usually what I'm concerned about when I think about speech language disorders, I think about receptive and or expressive language disorders. Okay. So those are disorders in a sense where children have a delay in what they say and or a delay in what they understand. Okay. Or as I've alluded to, both, which in my experience, both is most common. But what I need to understand is, is this a child who they don't communicate well, or they don't use their words at a developmentally appropriate level? Is it because they have delays in what they say and understand? So usually how I figure that out is I start with what the child understands. I ask questions like, can we do a one-step command? Can you do a one-step command, with a gesture? So we're talking 15 months, 18 months, one-step command with a gesture, one-step command with no gesture, just do it. Take your shoes, put them by the door. Then it gets a little more complicated. Take your shoes, maybe we're getting closer to 36 months on some of these skills. Take your shoes, put them under the steps. Take your shoes, put them on top of the stove, something like that, right? That gets a little bit more nuanced, but it gives me a sense as to what this child understands. Okay, so if your child has a language delay, a speech language delay, a delay in what they say, I want you to ask yourself, what do they understand? Do they understand body parts, pictures in a book? At 24, 30-ish months kind of skill sets. I mean, I'm generalizing. I know that there's more specific guidelines there, but, do they understand, one-step commands, two-step commands? Do they always need a gesture? If those things are true, and they're, past 15 or 18 months of age, they're between 2 and 3, or if you're watching this, your child's maybe closer to 3. If those aren't milestones that your child is demonstrating, then it's very possible that they have a receptive language component. So they have a delay in what they understand. Expressive language is just exactly what you think. So maybe which is expressive language is why they get to the clinic to begin with. So maybe you're 2 years old, you're using far less than 50 words. You're not putting 2 words together. Those are a simple 30,000-foot overviews of difficulties that kids may have as it relates to expressive language. But we have to ask ourselves, is this a receptive and expressive language disorder? Is that the nature of this? And if so, we need to get this kid to a speech therapist. Another layer to this, okay, is I will start to ask open-ended questions. Okay. So once I do some yes, no's or some commands, I'll ask open-ended questions like, what's your favorite color? What do you want to be when you grow up? These kinds of things. These are difficulties that, these are questions that require a higher level skill set to answer. And they can give you a better sense as to, how delayed we are in our receptive language skills based on the age of the child. So if your child's, between 2 and 3 years of age, and they have more than a subtle delay, meaning less than 50 words, not putting words together in a sentence into short utterances, there's likely a speech language component here, but then I want you to think about, what do they understand? When I give them a request, when I give them a command, do they understand body parts, pictures in a book? Like, where do their receptive language skills end? And then, what kind of a further evaluations do we need to consider? And usually it's a speech therapist. One additional thought on children who have speech language disorders. Sometimes it's that you have to zoom out a little bit. An example of this would be like selective mutism. Okay. I see lots of kids, and I should probably do a whole live stream on this, but selective mutism is a really nuanced and often difficult to navigate, certainly for the patients and the families, but also as a provider, it can be difficult. And selective mutism is a child who, presents with a speech language disorder, but it's very conditional. Okay. So an example would be, this child doesn't really communicate effectively at school, right? Minimal eye contact, doesn't use a lot of words to express themselves, doesn't answer questions, is just kind of really withdrawn. But then in the home environment, you get them in the back of the Subaru, and it's like, I'm telling you everything there is to know about geography and about my favorite color and about science class, and then they talk at home, but they don't talk in the community. So that would be an example of a child with maybe what appears to be a speech language disorder as it relates to the community, but in the home environment has relative strength. So that would be one additional nuance to consider in terms of speech language disorders. That is the second reason why kids typically don't talk. Here's the third reason. Okay. Here's the third reason. The third reason is cognitive delays. Okay. Now, this has some overlap into what we just discussed, because you have cognitive delays. What I mean is, your child may be 3 years old chronologically. Okay. Their body is 3 years old, but their problem solving skill set might be closer to 15 or 18 months. Okay. And how do you know that? Well, you go back down the ladder where we just were. So you got maybe a 3-year-old, and I'm asking questions like, one-step commands with a gesture, one-step commands without a gesture, body parts, pictures in a book. I'm kind of trying to survey the cognitive skill set of this child. But the difference between a child who has a receptive expressive language delay or disorder and a child who has a cognitive impairment or an intellectual disability, or you're concerned about that, is the presence of global delays, right? So when you're thinking about speech language disorders, you're thinking about a sliver skill set, right? There's all these different developmental spheres. There's problem solving, there's personal social, there's fine motor, there's gross motor, there's all these kind of skill sets that people get pretty good at assessing. But when you've got a blanket that's kind of been thrown over all those skill sets, so it's not that you're just delayed in your talking, but maybe you're delayed in your walking, delayed in some of your problem solving skills, delayed in your receptive language. You're showing a lot of delays in your ability to acquire new information and build on those things like ABCs, or, drawing out sentences into longer structures. Then maybe what we're talking about is a level of intellectual delay. And essentially what that means is that we need to think about cognitive assessment with a psychologist in order to figure out where that child is from a cognitive standpoint in a more formalized and standard way. Okay, let's do the fourth reason. Okay, you can see it on the screen here. Listen, the fourth reason why people are often referred to the developmental clinic is because they're concerned about autism. Okay. If you're watching this, if your child has a speech delay, it is an absolute guarantee that someone in your life has floated the idea that this child may have an autism spectrum disorder. The reason I know that is 20 years of doing this, thousands and thousands of evaluations. And I will tell you, people are trying to help you. They're trying to be, they're trying to find reasons. I mean, honestly, my experience with suffering and struggles in the clinic is that people try and navigate these things by making sense of it, right? Like kind of hanging that unknown, that struggle that they're having on the hook of something that makes sense, like a hall tree, like, well, maybe it's an autism spectrum disorder, or maybe they just, there's all these things. And those are important things. You should think about that. That's why I'm doing this talk. But it's very common when I do these evaluations to go through these progressions: hearing, speech, language, is it an intellectual impairment, or is it an autism spectrum disorder? Because individuals with an autism spectrum disorder can present with all of the things that we've just discussed, but I want to add one additional log to the fire. Okay. Because people could listen to this and say, well, how can you tell the difference between theirs, or how are not all of these just an autism spectrum disorder? And I would say, well, you're asking good questions, but I want to throw one more log on the fire. Imagine that you've got a child with receptive and expressive language delays, maybe some anxiety issues. Maybe there's a level of intellectual delay. We're not sure because there's not a lot of compliance with, commands, or not a lot of interest in building on some learned skills. And then you add on top of that a decreased or diminished intent to communicate in all environments. Okay, not just at school, not just at home, but a decreased or diminished intent to communicate. That's not the only way to think about an autism spectrum disorder, but when you're talking about kids under the age of 3 or 4, I would suggest to you that's a really helpful way to think about it. Now, certainly you can have kids diagnosed autistic who have great language skills in the sense that they can talk about all the different things. But then you get into the nuances of it. Well, we're only really talking about the solar system, though. I mean, I love renal physiology just as much as the next person, but man, maybe we could talk about the bears. Actually, maybe let's just talk about renal physiology. That's probably more interesting at this point. But let's, so you can have great language skills, but then it can be so lopsided, one-sided, and perseverative that you can also be on the spectrum in regards to an autism diagnosis. But in general, when you think about autism, for those of you who are new or you're trying to figure this out and you're watching this because you're scared about a kid that you have or that you care for who has speech delay, I want you to think about the first 3 things that we've discussed. I want you to really interrogate those problems. And then I want, as you think about autism as the 4th possibility, I want to give you a couple things to think about. As I've said, autism in the ages under 3, from my perspective, is a lot of things. Okay. But it starts with language delay. But really it's, in addition to the language delay, it's a decreased or diminished intent. Like, I don't maybe possess a lot of language skill sets from a developmental perspective. I need to do some work, need to build on some of those skills. But what I do have, I'm not necessarily going to use to help you know what I want. So here's how I ask this to families. I say, listen, when we're trying to figure this out and families they're struggling to kind of get what I'm trying to say, I say, listen, imagine that you go on a date, or you go out of town, or you go out for run some errands and you need a babysitter, and you call Noble, because in this scenario, we're best friends. And I come over to your house. I say to the families, I say, listen, am I going to be able to understand what your child wants? Now, families usually don't think about it like this. They usually don't think about it in that context. They're like, well, A, nobody watches our kid because we just don't, the language delay, we're concerned that nobody wanted to. So, and then B, like, they don't think about it because they get so good at reading this child's mind. They know that, and like an indirect glance at 2:00 means graham cracker, right? It's like, I don't know what that means as a guest in your home. So when I talk about a decreased or diminished intent to communicate, what I mean is that child maybe has skills to do a word approximation or even an indirect gesture, right? That would help throw me a bone so that I know what they want. And a child who's unwilling or unable to do that on a consistent basis to get their needs met, then I get concerned that child has a decreased or diminished intent to communicate. They're not trying very hard to use the skills they have to help me help them as a guest. Families don't think about it that way because they're really good about meeting the needs of the child, and they don't really ever think about how that would translate to somebody who's not good, who's not a wind talker, who doesn't understand how to crack the code, right? So I think about that first and foremost. Of course, when you think about autism, there's, deficits in social communication and interactions. And it's across multiple contexts. Sometimes the daycare the child goes to is chaotic, right? Or sometimes they live in a home that's super busy and there's a lot of people watching, screens because they're just trying to survive or whatever. And yeah, we need to infuse that kid into an environment where they get more opportunities to make progress. So I like them to go to school. I don't mind them going to to daycare if they're home. I like that for kids who you're concerned about an autism spectrum disorder if they have a lack of opportunity. They haven't received any services. They're not around any other kids. Maybe there's not a lot of direct language in the home spoken to the child. But if you see a child who's got persistent deficits in multiple areas, and it's from a social communication standpoint, so like I just discussed, like social communication is like, I talk, you talk. You may not have the words yet as I ask you questions, but you're looking at me, your eyebrows are up, you're smiling, you're excited about this interaction, but maybe we're not making a lot of progress in terms of the translation of information, but you're in it. We're doing it. I'm pointing, you're looking, I'm looking at my phone and laughing. You're getting over in front of me and be like, what are you laughing at on that phone? Somebody knocks at the door. I want to see who it is too, because it could be a package for me. I open up a box. I go, whoa, a kid comes across the room, looks in the box because they want to see what I'm looking at. This is what we call the sharing of delight. If you have a child who is not interested in sharing in the delight or the horror or the terror or the whatever it is that's happening in the family that elicits like a visceral response. I'm laughing. I cut my finger and I'm crying. I slam my finger in the door and now I'm hurt. Children are able to read the air even at a young age, and understand that the mood in the room, the tenor in the room has changed. Children who are not curious about that dramatic change in the scenery, the emotional scenery of a room, the opening of the box, the laughing at the phone. Children who are not interested in sharing in the delight of a caregiver, those are kids that I would say likely have a social communication or social interaction delay. Okay. So that's how I want you to think about autism, because it's a term that everybody throws out all the time. Just throw it out. Just say that. Say it all the time. Say it 1,000,000 times. I don't know that while diagnostic clarity is important, while autism is often a key that opens a door to very useful interventions and services and gives your team, your IEP team, your speech therapy team, your grandparent team, it gives them a roadmap. So important. I don't want to diminish the value of diagnosis. I don't want to diminish the value of putting a description in place that gives people a path that helps them understand from a therapeutic perspective, which is true north on the compass of therapeutic interventions. I don't mind that. I think that's important. I think it's useful. Okay. But I also want to say, before we keep moving on through this, that it's so important that we understand that a diagnosis does not replace a name. I see it all the time. People say, well, I had a guy ask me one day, what should we do? And after we talked about the new diagnosis of autism in a child. And I say, well, sir, I can tell you what not to do. Okay. What I would not do is go headfirst into every super toxic Facebook group and just have people throw rocks at you because you're not using terms correctly, because you said autism instead of autistic. And I get it. Like there's no true consensus on how to talk about it. It really comes down to how you as a family value this, and how you want to discuss it in and amongst yourself. Okay. No matter what you might feel, or no matter what you may have been told or led to believe on social media or in the media in general, there is no one way to talk about autism. An individual can be autistic, and be kind of diagnosis driven in terms of identity. They can have autism and be more, and be driven by another kind of nomenclature or structure. So there's no real true right way to do it. Okay. But it's important that we don't throw stones at other people for the way that they want to describe it. I would say, so that's an example. Don't do that. Maybe don't lead with a diagnosis whenever you introduce your child to the school or the district. Usually you'll start with a name because, your parents, but then the next thing you say doesn't have to be, he's autistic, he has autism. I mean, you need to give people a heads up. People need to understand strengths and weaknesses, but I also want to know if he's what he likes. Like, does he like Superman? Is he a DC guy? Is he a Marvel guy? Like, I just want to know stuff, right? So often it's easy to lose the name, the essence, the ethos, the joie de vivre of a child, as we mask it behind a nomenclature that we co-opted from the DSM-5. Okay. It's a lot more complicated than that. So persistent deficits in communication, I look for restrictive, repetitive and behaviors, interests, and activities. So I look for kids that I ask questions like, look, what's your child play with? right? Now, a lot of 2 and 3-year-olds, they have a couple things that they enjoy, but I want to know, does this child have one thing, and is it a toy, or is it like a whisk? Something that's maybe a little less functional in regards to imaginary play skills. And then I also ask, if you just left your child alone to their own devices all day, you just left them alone. Now, that seems crazy, right? Who would do that in a 2 or 3-year-old? But let's just say, if your child could have their perfect day and you just left them alone in their room with all their high preference activities, what would they do? And if the answer is, they'd stay in there most all the day, would they come looking for you just to kind of check in and see what's going on? And, and they'd say, nope, only to get needs met, or to make like if they need water, or if they had their diapers wet or something. That is an example from my perspective of a child who's got pretty restricted behaviors, interests, and activities. So restricted that they're not diversifying enough to interact with family. Okay. Now that's not a slight to these individuals. That doesn't always stay like that. Okay. But I'm just letting you know, like when we're talking about the fourth of the 4 reasons why kids don't talk well, these are the questions that I ask to try and get to the truth. The symptoms have got to be present early. When you think about autism as a diagnosis, you don't catch autism at 12 or 16. Now, were the deficits present before? Yes, but maybe your child had strategies and abilities that were able to compensate for those struggles. I think there's some leadership book in the 70s where it talks about you graduate to your level of incompetence. So your kid was able to kind of compensate. And then 6th grade comes and there's all these transitions and there's all this sarcasm and everybody's got a smartphone now. And then it's easy for kids to kind of, fall off the trail in terms of their social skills. And it can become more evident then. So you can be impaired later, more so, but you have to have evidence of some struggle early in life. So think about the kid who was delayed in their talking, maybe had some speech therapy, maybe had some perceptive issues or some hand flapping or toe walking or ear covering or selective diets, but they kind of were able to move through it and do okay, didn't pop up on anybody's radar. Those kids can certainly be diagnosed with autism later in life when they do become impaired. And then, lastly, I want to say, as we close out this 4th reason why kids don't talk well, I want to talk about how, the symptoms of autism need to be clinically significant. The impairment needs to be present in school, in social settings, occupational settings, in other areas where, functioning is key or important. And I think that's where there's a lot of disagreement as to what we would actually call impairing, and how we define impairment. And I know I have a very specific way that I define impairment, and that's essentially, it's the same with ADHD. It's like if your life is a dumpster fire, right? Don't call a developmental behavioral pediatrician. Don't call a geneticist. Don't call a psychiatrist. Don't get these people involved unless you have a forest fire to deal with. Okay. Like our job is to fight fires. It's not to fight campfires. Okay. And I think there's, in my mind, impairment means I'm unable to be successful in the areas of life that matter most. Now, what I did not say is I'm unable to be the most successful at work. So therefore, I got to go hunting for, some problem. Now, this is not necessarily an autism discussion. This is more of an ADHD discussion, but it's important that people know that you don't have to be the highest of high functioning in every environment, right? That doesn't mean that you're impaired. Now, you could make an argument, well, if I didn't have these issues, I would be able to function at this level. So then, essentially I am impaired. And I think there's a point to be made there. But in general, I'm talking about a dumpster fire problem. All right. I think that's when a diagnosis is useful because it opens up doors for therapeutic interventions that are going to really, really help. Okay. So that, my friends, that is the 4 reasons why children don't talk. Now, let's end our time with, or I should say, let's talk about our last topic together. And this is pharmacologic forecasting. Now, this is a different topic. The reason we're doing this show is because I want to answer people's common questions. I want to get this information out there, readily available to you. As you're waiting on a wait list or you're thinking about being placed on a wait list, I want to be able to answer those questions for you as quickly as I can. And so one of the questions we get a lot is in regards to medications. Like people want to know, what do we need to do with these medications? Is this child, does this child need a medicine, or how do we want to handle this? But of course, the better question is, how do we keep kids off medications in general? Nobody wants kids on a medicine. I say this every live stream. Doctors aren't driving around in white vans trying to figure out how to throw pills in kids' mouths and then laugh. That's not what we do. That's not at all what I want to do. I want to get kids off medicines. I want to have pharmacologic garage sales, right? But in terms of forecasting, if we're on a medicine, right, we've identified that this is a good fit. We need to treat ADHD. If you're talking about an individual with an anxiety-mediated struggle or a sleep onset issue or transition difficulty or self-injury, there's a lot of reasons. There's a lot of indications for medications. But first and foremost, we decide on those indications based on impairment. As I said earlier, these kids' lives are a dumpster fire. So if you're watching this and you're like, well, I don't know, my kid's on a medicine, but I'm not really sure it's that useful. We skipped some doses and, his life wasn't terrible. The Jenga tower didn't fall to the ground. Maybe you don't need to be on that medicine. Okay. The kind of kids we're treating are the kids that are so impaired that it's a dumpster fire if they're not on the medication. That doesn't mean that they can't come off, but it means we got to be strategic about how we do it. But if you're on a medicine and you're watching this because you're like, well, I don't feel good about this, or I need just a way to think about medicines, I want to give you a few ways to do some pharmacologic forecasting with your provider. The first of which is what I'm calling the rule. I say that like this is a clever title. It's not. The rule of threes. It's not. But this is how I think about things. Okay, if your child is on a medication or you're managing a medication, managing medications is a lot like watching somebody play chess. I play chess and I'm terrible. Like by chess, all I know is I know how the pieces move, and that's about it. My brother, he beats me, and I remember last time I played him, he beat me in like 3 moves. It was embarrassing. My sons, I've got nephews and nieces, they'll beat me. They're like 8 or 5. They'll just destroy me. Okay, but I'm not good at chess. But what I do know is that people who are good at chess, they don't think 1 move ahead. They don't think 2 moves ahead. They think multiple moves ahead. They're like not even playing the game in front of you. They're playing a game that's not existed yet and all the possible realities of that game. That's how these people do stuff. And medication management is not that different. The rule of 3 starts with 3 smart things. If you're on a medication, if your child is on a medication and you go to your primary care provider because it's not working, what I want you to understand is that you need to be a part of the pharmacologic forecast. You need to provide information. You're like a barometer. Okay. You're like a storm chaser. You have to bring necessary information to your provider so that we can collectively with you think about what is the next best step. The first is to do 3 smart things. The medicine's not working. Let's do 3 smart things before we, get aggressive with changing anything. Okay. The first step in doing smart things when your child's on a medicine is to optimize the medicine they're already taking. Okay. There's a bunch of metaphors I could use here, but suffice to say, because I know you're smart people, it is the best way to proceed when you're dealing with a child on a medicine that's not effective is to ask yourself, is this medication appropriately dosed? That being said, parents, one thing that I rarely, if ever, say to you is, let's increase the dose. I say it sometimes, okay, when I'm not thinking, but I don't like to say it that way because if I'm a parent, which I am, and I've had kids on medicines, which I did, I don't want to hear about increasing a medicine. I get it. If your child's on a medication, you're already, feeling a lot of the fear, guilt, and shame that comes with that. Okay. So me telling you that we're going to increase the dose doesn't make anybody feel good about anything. And I get it. So what do? We optimize. We're not going to increase. We're going to optimize. But the reason we optimize the medication you're already on is because there's only so many levers you can pull. Friends. So please don't skip this step. Get more out of the medicine you're taking if it's appropriate. Okay. Next, give it with food. Change the time of day that you give the medicine if you can. Some medicines you cannot, like ADHD medicines, stimulants, you give those in the morning in general. Okay. But give it with food. But if you do give it with food, don't give it with acidic food. Don't give it, if it's an ADHD medicine, it's not working. Don't give it with orange juice or, ascorbic acid. Don't do that because it can lessen the utility of that medication, surprisingly. So don't mix up how you're giving it, but give it with food. Change the time of day. If it's an anxiety medicine and you feel like compliance isn't there, you're struggling at certain parts of the day, give it at bedtime. That's a good way to do that. As an example, talk to your provider about all these things. Okay, so that's the first of the 3 rules. Okay, the second rule of 3 is think 3 steps ahead, as I said earlier. So if you know that this medication is not working, what's the next and the next and the next medications that you could potentially use? What should you do next? And then what should you do after that? And a good provider is going to put that in their notes so that if I get hit by a bus, I tell families, if I get hit by a bus, any one of my amazing partners is going to be able to come in and do a better job because I left a breadcrumb trail. Okay, so ask your provider, what are 3 steps ahead? Do you know? Well, and the answer is increase, increase, increase. I don't know that that's exactly 3 steps ahead. I mean, it is kind of, maybe that's 1 step ahead, optimize the medication you're taking, but then is what are you going to do after that? Okay. And then lastly, okay, now this is more directed toward you guys. Don't get mad at me, parents. Don't get mad at me. Okay. But listen, if you are the third of the 3 rules, okay, the rule of 3, the third is if you're making 3 or more phone calls to your provider a week, something probably needs to change. Okay. Probably either your expectations or your provider. Okay. Because if you're in my clinic, I'm telling you, I'm loving you and I'm wanting to help you so much, but the likelihood that we're going to find a higher level of care for you is really high because it's clear that I can't meet your needs if you're calling that much. 3 times a week. I love you guys, but that's a lot of times. Now, if you're in crisis, if you're having bad side effects, of course, we want to hear from you. But as a general rule, if you're calling 3 times a week, every week, I want you to know that the cadence of that concern is a bit of an outlier as it relates to developmental behavioral pediatrics. Okay, so there's that. And then lastly, my last thing I want to talk about with you is be careful what medications that you're taking and how high up you go on the doses, because some medications, if you're working with your provider, the question you need to ask them is, are we able to back out of this? You get up to a certain dose on certain things and then you're kind of stuck there. You bought the car. So now you have to just deal with it for a while because coming off of it can be problematic. So the question you have is not just what medicine should we start, but doctor, our provider, how easy is this medication to discontinue? All right. Let me close with a few public service announcements. We have a couple classes coming out that could be really helpful. Okay. One of which is called Assess and Address in 60 seconds or less. And it's just about how do you address behavioral problems in children and not make them worse. Okay. I didn't say you can fix them. I didn't say you can magically make everything better. But one thing, what the best place to start is not heading in the exact wrong direction for 6 years. Don't do that. That never ends well. Really hard to untie that knot. Another class that we're making available in the very near future are the 5 pillars of autism care. We want you to understand kind of a entry-level master's class, like what do parents and new individuals navigating this diagnostic nomenclature, what do they need to think about? What do they need to understand? What are the 5 things that they must do or decide on immediately, okay, as you're navigating this, even before you receive a diagnosis. Okay, as always, you can see more of our information on my website. It's right there. And that is where you're going to go and sign up for the newsletter. The newsletter is a very good newsletter, and it tells you about these classes and it recaps some of the stuff we just talked about, and it adds new and interesting stuff, and that's going to be coming out very soon. So join the newsletter and you'll learn about all the new classes that we offer. And of course, lastly, like and subscribe so that we can get this information to people who most need it. I want to thank you sincerely for your time, energy, and resources, and I will see you next week, Thursday, 9 a.m. Central Standard Time. All right, everybody, have a great week, and I will see you then.